morning, everyone. Welcome to today's Public Health Ontario's Grand Round session. The title of today's presentation is Evidence to Inform Policy Options for the Elimination of Hepatitis C Virus in First Nations Populations in Ontario. My name is Michelle Murdy, and I'm the Medical Director of Public Health Ontario, and I have the pleasure of moderating today's session. Before we start with today's presentation, I'll mention a few housekeeping items. The Zoom platform allows attendees to have the ability to customize your own view. You can do so in the right-hand corner of your own screen. Please use the Q&A pod if you have any questions during the session. We will save questions until the end of the presentation. The chat pod has been disabled to limit any distractions during the presentation. If at any point during the session you experience any technical issues, please email events, E-V-E-N-T-S, at oahpp.ca. I'd like to state that as the moderator of the session, I do not have any potential conflicts of interest to declare. It's now my pleasure to introduce the speakers for today's presentation, Andrew Mendelowitz, Evelyn Hill, and Lindia Jones. Andrew is a PhD candidate in Health Services Research at the University of Toronto. He holds an Honours Bachelor of Science degree in Biology from York University and a Master's of Biotechnology degree from the University of Toronto. He's also a doctoral trainee fellow with the Canadian Network on Hepatitis C, or CAN-HEP-C, and a research trainee at the Toronto Health Economics and Technology Assessment Theta Collaborative. Evelyn Hill is a registered nurse, Mohawk Bear Clan of the Six Nations of the Grand River, and employed by Six Nations Health Services. Evelyn is a Six Nations representative on the Ontario First Nations HIV/AIDS Education Circle, or OFNHAEC. Lindia Jones is from the Shawanaga First Nations and is a health director with the Independent First Nations of Ontario. Lindia has been a member of OFNHAEC since 1998. And with that, over to the group for their presentation.
Good afternoon, everyone. My name is Lindia Jones, and I want to do a land acknowledgement before we begin our presentation with you. So first of all, I would like to acknowledge, as an Anishinaabe Kwe from Shawanaga First Nation, I'd like to honor my brothers and sisters on the traditional territory of the Mississaugas of New Credit in the Haudenosaunee and the Wendat peoples. As you know, that this land, this territory is diverse to many First Nations and Inuit people. So I just wanted to pay respects to that when we come to in our treaty or territory areas that we have the respective protocol of acknowledging their lands and territories. So I just wanted to acknowledge that first. Next slide. So I guess I'm the one that's doing introductions here, just to kind of give you, as it was mentioned, I have been an OFNHAEC member since 1998, so that's been a pretty long time. This research that has been being presented to you today has been many years in the making. For many years, for First Nations, we're very reluctant to partner with researchers, as we've seen negative impacts from research and studies done on Indigenous peoples in Canada and around. So this was a first time in making and looking at and respecting OCAP principles. So this is as you can see, a good partnership right across that where this research has flourished, and I hope that we create further partnerships down the road. So I introduce Andrew to start going through this research that we partnered together with. Thank you.
Thanks, Lindia. So I just want to say, this research team has consisted of clinicians, First Nations researchers, and experts in health technology assessment, all with the purpose of providing evidence of the impacts of HCV infection on the First Nations population in Ontario. So just to jump right into it. The learning objectives for this presentation were essentially to have an understanding of some of the health and economic impacts of HCV facing First Nations populations in Ontario, discuss how HCV elimination efforts can be tailored differently to the experience and needs of First Nation individuals in Ontario, and explain how this evidence supports Canada's recommendations for what is needed to achieve HCV elimination by 2030. So I'm going to start with the key findings, and we're going to elaborate more on how our study has informed some of these at the end. So the key findings of this work were rates of diagnosed cases of hepatitis C infection among status First Nations populations in Ontario were high and have increased annually since 2006. That being said, we saw parallel increases in the rates of HCV testing in status First Nations populations in Ontario. And lastly, we also looked at healthcare costs associated with HCV infection, and they were high among status First Nations in our cohort. So just to jump right into it. So in Canada, there are around 220 to 246,000 Canadians living with chronic infection. So Hep C is curable, but almost half of those who have it are unaware of their diagnosis. And by the time they figure it out or they develop cirrhosis, without treatment, over 41% of those infected may develop liver cirrhosis. Now, of the limited or minimal research that has been done looking at Indigenous peoples in Canada and Hep C, they've estimated that the rate of infection among Indigenous people in Canada is up to 5 times higher than the rest of the population. And among the research that has been done in Ontario looking at First Nations populations, they've associated infection with a younger age of infection and higher rates of newly diagnosed infection. So I just want to put up this slide because with this quantitative data, it's really easy to forget about, it's really easy to lose context as you're looking at these rates of illness and rates of testing. So just to preface, when thinking of the impact of HCV on Indigenous health, it was really critical to first try to understand how Indigenous people define their health and well-being. So within the realms of Indigenous health, health has been theorized as an overarching holistic concept rooted in spiritual, emotional, mental, and physical elements. In addition, health has been compounded with considerations of the past, present, and future. So diagrams such as this tree here and similar tree models have been used to demonstrate the complex and interconnected systems that link together Indigenous social determinants of health. So the distal determinants here that make up the roots of this tree include the effects of colonization and its linkage to intergenerational trauma. And in the context of Hep C, the impact of these distal determinants make up a risk exposure that's unique to Indigenous populations in Canada. And these distal determinants in other research have been linked and have created etiology for manifestations of substance abuse, which is one of the primary risk factors of Hep C infection. The intermediate determinants consist of those around environmental and healthcare systems, and these include things such as food security, housing, education, and cultural cohesion. And these represent factors that really impact community health and well-being. And in the context of HCV, these factors also impact access and barriers to treatment and testing. And in combination with the proximal factors that are more direct healthcare behaviors and the distal determinants, it's important to think of all these things together as complex and interconnected factors all impacting Indigenous health and wellness. So I just wanted to mention that as we go through our results and something to think about too. So in 2016, the World Health Organization released this global strategy to eliminate hepatitis C virus by 2030. Now, complementing this strategy, they came out with the Blueprint to Inform Hepatitis C Elimination Efforts in Canada, and this was created by the Canadian Network on Hep C. Now, within the Blueprint, they outlined priorities, recommendations, and perspectives for what is needed to achieve HCV elimination in Canada. And within the Blueprint, and as a part of Canada's commitment to First Nations people, First Nations populations were identified as a priority population. And essentially, the Blueprint has called for First Nations representation in HCV monitoring and surveillance, the creation of First Nations-led approaches, especially in HCV prevention and treatment strategies. And the Blueprint has suggested how this work to eliminate HCV can fit into that greater spirit of reconciliation. So what I want to stress is there's a research gap here. So there have been a few studies that have analyzed the impact of HCV on certain First Nations populations in Ontario. Now, of the research that has been done, these estimates have been relatively community or region specific, so they are more limited in their scope. There is that lack of province-wide evidence when compared to other provinces that have it. And practices in culturally safe handling of the HCV epidemic still remain unclear. So a reference point is essentially needed to inform the necessary health response for HCV elimination. So before I get into the administrative data that drove our studies, I thought now would be a good time to just kind of see if maybe anybody in the audience would like to maybe knows about this, but I wanted to answer the polling question 1. So with respect to performing First Nations research using administrative health data in Ontario, this is specific to through that offered at ICS, which of the following do you think is required? So I thought now would be a great time for we answer the poll. Okay. So if you want to see the poll, you just need to click on the poll button at the top of your screen. Sorry for those who can't see it. Okay. So 87% clicked all of the above, which is correct. So the administrative data used for this work originates from ICES in Ontario. So ICES, for those who don't know, is a not-for-profit research institute that houses all Ontario health-related data. And this includes clinical and administrative health and social science databases. Now, in October of 2017, after several years of working closely with First Nations partners, ICES formalized an Indigenous portfolio. And under the governance of the Chiefs of Ontario, ICES received the Indian Register from the federal government, and they linked it to their existing administrative data sets. And what that allowed for is the identification of status First Nations people in Ontario. And after linking this register to their data sets, it essentially created the largest First Nations study cohort in Canada. Now, on the right here, we have the created established framework that guides the usage and process for working with Indigenous health administrative data. And this framework highlights commitment to First Nations governance principles, the formation of relationships, capacity building, and knowledge exchange. So what I want to stress was the work we do here, the work we're about to present was reviewed for OCAP compliance, First Nations data guidelines around ownership, control, access, and possession by the Chiefs of Ontario Data Governance Committee, and permission was also obtained from Grand Council Treaty 3. The Kenora Chief Advisory data was excluded from this analysis. This data was then linked to Public Health Ontario data sets that contain HCV testing records for the province. So the purpose of this research was to provide evidence that can inform policy options for HCV elimination efforts in First Nations populations in Canada. The first part focuses on examining trends in the testing and diagnosis, and the second part focuses on estimating the economic impact, essentially the costs of care associated with infections specific to First Nations people in Ontario. So I just want to stress that critical to doing this thesis work was to work in partnership to understand the needs of and engage our First Nations partners and stakeholders. As such, OFNHAEC, the Ontario First Nation HIV/AIDS Education Circle, our advisory group, and we're partners on this work. And OFNHAEC is involved in supporting and educating First Nations communities, families, and individuals in dealing with the challenges of HIV, HCV, and other STBBIs. And this partnership was built on concepts that ensure incorporation of First Nations ways of knowing and anti-colonial approaches to research. And this includes things like the formation of reciprocal relationships that are focused on the co-development of knowledge and following tools and guiding principles essential to First Nations data sovereignty, such as that OCAP compliance and permission and review of the research from all groups involved. So this work started around October 2017, and OFNHAEC has been involved at every step, and quarterly meetings between OFNHAEC and the research team has essentially incorporated their feedback into study conception, design, analysis, and interpretation of study results. And this has ensured that cultural understandings are involved in the study and the results are usable and can be used to empower OFNHAEC's programming and action around HCV infection. So just to jump into the first part of the study, our goal here was to use the administrative data to estimate trends in Hep C testing and diagnosis. And complementing this was the blueprint's recommendation to disaggregate data and to measure and monitor, to disaggregate data and represent and measure and monitor the impact of infection on different populations in Canada. So just looking at our study design, what I want to emphasize here is we examined the impact of HCV among status First Nations people in the province, and we did not compare it to those of non-First Nations like other studies have typically done. Using the latest data of PHO data available at the time that is linked to ICES, we looked at the prevalence and incidence of infection and testing from 2006 to 2014. That being said, we also described cohorts of those tested, those diagnosed, and those with no test record up until the end of 2017. And essentially, we compared those who were diagnosed, tested, and without a record in the PHO data. So here we have testing rates. The three lines represent the overall testing rate, the testing rate of those who resided within First Nations communities, and the testing rate among those who resided outside of First Nations communities. Now, for incidents of testing on the left here, we followed individuals until their first testing date. And what we saw is this increase in testing from 12.1 to 21.3 people receiving a first test per 1,000 person years. On the right here, we looked at the point prevalence at the end of each year to see how many individuals were ever tested each year. And just to stress that these 2006 values incorporated the 1999 to 2004 period. And what we see again is that point prevalence more than doubled from 6.3 to 16.2 per 100 people. Now, this was really interesting. Once we stratified rates by those who live within and outside of First Nation communities in each annual period, although cumulatively we saw more tests being performed in First Nation individuals who resided outside of First Nation communities, we saw a larger increase within. And you see this spike around 2012. This spike may be due to the availability of direct-acting antiviral medications. They launched around 2012 and they became more widely available around 2014. Now, looking at diagnoses, these graphs show the rates around diagnosis of infection, and they look specifically at time until first Public Health Ontario recorded date of diagnosis. And what we see here is that general trend again in this increase in diagnosis of infection. And this is likely due to the parallel increase in testing we observed before in the results. And once again, when we stratify these cases of diagnosis of infection by those who reside within First Nation communities, although we saw more cases of infection cumulatively overall in those who reside outside of First Nation communities, we saw a larger increase over time from those who reside within. Now, when we also broke down these rates by LIN, essentially region in Ontario, Local Health Integration Network, and identified via postal code and residence code. And what I want to emphasize on these slides and these four maps that show the point prevalence of ever tested, the point prevalence of diagnosed infection at the top, and then at the bottom it's the two incidence maps over time, is we essentially saw that same correspondence where in regions of high testing, they corresponded to a high rate of diagnosed infection. So what I want to stress here is just to discuss, most individuals were less than 40 years of age. But that being said, the First Nations population in Ontario is generally younger. Remember, our comparator group here was not non-First Nations. It was the rates of infection and testing among status First Nations in Ontario. Now, we did see more females tested, but we did see more males diagnosed. Now, we saw higher rates of infection, specifically we saw 2% among First Nations people in 2014, where the prevalence, the national prevalence rates have been around 0.4 to 0.6%. They were around 0.5% in 2011. That being said, we also saw success among testing strategies, especially with the increases over time. We saw a lot of success among those who reside within First Nations communities. Now, one thing I do want to stress is these rates really only paint part of the picture, as HCV is asymptomatic. So the true incidence and prevalence of infection is likely much higher. So our second study essentially focused on measuring the economic impact of infection, specifically the cost of care associated with infection. And this is important as the costs associated with treatment and managing complications of HCV can be relatively substantial to the healthcare system. And that being said, there have also been no studies looking specifically at incurred healthcare costs among First Nations populations. So looking at the design of this study, what I want to emphasize here is similarly, we looked at costs within the population or among First Nations people. We didn't compare to non-First Nations. Now, we used the same PHO data that spanned 2004 to 2014, but we followed these individuals from 2004 to December 31st, 2017. And we looked at the provincial total and net healthcare costs for 30 days in 2018 Canadian dollars. So to measure the cost of infection, we used a phase of care approach, which essentially breaks down hepatitis C into 4 phases with start and end dates determined based on joint point analyses results in expert opinion. So we broke down Hep C into these 4 phases. There was a pre-diagnosis phase, which consisted of a fixed length of 6 months before infection, an initial phase, which consisted of that period following diagnosis, a late phase, which consisted of the point when liver disease develops, and a terminal phase, which consisted of 6 months preceding death from any cause. And within each phase, individuals with Hep C infection were matched up to 2 individuals without infection to measure the net cost or the cost associated with infection itself. So just summarizing the mean costs among those with infection per 30 days, what I want to emphasize here among the cost resource categories is inpatient care accounted for 30 to 50% of the healthcare costs in the pre-diagnosis, initial, and late care phases. The scale is a little bit different here in terminal phase, but inpatient care accounted for 60 to 70% of the total costs in terminal phase. So that's what drove the costs associated with HCV. Now, looking at the net cost, which is essentially the cost of cases minus the cost of our First Nations controls, what I want to show you here is, so this is the net total cost of infection. And what we see here is that the cost associated with infection greatly increased when late phase advanced liver disease and terminal phase developed. And what's important here is if we do not treat and find these cases of infection now, these high costs of late and terminal phase associated with infection are forthcoming. Now, we also stratified our costs among cases who resided within First Nation communities and their associated matches. And what I want to emphasize here is that total net costs were higher in the initial, late, and terminal phases for those who resided outside of First Nation communities. But what we saw the greatest difference in net costs between community status in the terminal phase. And after discussing the potential roots of these differences with OFNHAEC and looking at what literature does exist in the area, we attribute this to different supports available for end-of-life care and limitations in access to care for those who live within First Nations communities. So that's what we attributed to these large differences of costs exhibited in the terminal phase. When we examine the net costs associated with infection by sex, in the pre-diagnosis, initial, and late phases, females exhibited a higher net cost of infection than males. But in the terminal phase, this actually switched, where males had a much larger net cost of care associated with infection. Now, after looking at existing literature and discussing these differences with OFNHAEC, we attributed these to differences in healthcare-seeking behaviors. So of the studies that have been done in First Nation populations, they have indicated that women may be more likely to have a family physician and seek healthcare services than men. And this was perhaps due to cultural norms regarding male strength and the perception of symptoms. And males may essentially seek healthcare only when disease has progressed to a critical stage. Also, from our feedback with OFNHAEC, females may also choose traditional medicine and community supports rather than hospital or hospice care at the end of life, and those wouldn't be captured in the administrative data. So that's what we attribute that difference to. So significant points of discussion here are that the costs were high. When compared to the average national healthcare expenditure in 2014 and similar phase of care studies done to measure the cost of hepatitis C in BC, our costs were much higher. Now, our costs did substantially differ by community status and sex, and we attributed this to different healthcare seeking behaviors. Now, I do just want to mention, like, a significant limitation of the study is the study really captured provincial costs because ICS lacks non-insured health benefits data and data for those who go out of province for healthcare costs. So it's important to think of that, especially when thinking about healthcare access within First Nations communities, because we didn't capture the non-insured health benefits data and costs. So from this point, we're just going to bring everybody's up to speed on our findings and refresh them again. And I just wanted to bring in polling question 2 before I hand it over to Evelyn. So from 2006 to 2014, the rates of HIV testing among the cohort of status First Nation individuals in Ontario exhibited what? So I can't see the answer, but 62% picked A, and so A is correct. Although cumulatively we saw more cases of infection outside of First Nations communities, over time, those annual increases, the trend, over time, the trend we saw is an increase, a higher rate of increase within First Nations communities. Okay, so now I'm just going to pass it over to Evelyn.
So back to our key findings results. So the rates of diagnosed cases of hepatitis C virus infection in status populations in Ontario are high, and they have increased annually since 2006. So they found a prevalence of 2% among the First Nations people, which is higher than their national average of 0.5%. Our rates of the hepatitis C virus testing in status First Nations populations have also increased over time. Our testing strategies and approaches in First Nations populations are successful, especially within our communities. Successful partnerships are the key, and that is between our First Nations communities and our local health integration networks to formulate accessible and culturally appropriate healthcare services, especially we've noted in our mental health and addiction teams. So thirdly, the healthcare costs associated with the hepatitis C infection are high among our status First Nations individuals. The costs were nearly 1.5 times the average Canadian healthcare costs and higher than BC estimates of the cost for the hepatitis C infection rate. As Andrew mentioned, costs of the late and terminal phases forecast the economic impact if this infection remains untreated or diagnosed late. So moving towards hepatitis C viral infection elimination, we're considering the surveillance, so monitoring the progress towards elimination of the infection. Elimination efforts would create a case for investment in our hepatitis C infection preventions and treatment efforts. So efforts will need to be strength-focused and tailored to the experience of our First Nations individuals. And also with this blueprint empowerment, because this would inform our Ontario First Nations HIV/AIDS education circle programming, as well as directions to our community leaders and decision makers. Next. Go ahead, Andrew.
Oh, so just to close this presentation, as this was one of the first projects to actually gain access to the Indian Register that has been linked at ICS and go through that process of gaining access to First Nations health data, I just wanted to reflect, and I think it's important to stress, reflect on all this work that has resulted from this collaborative research and what lessons have really come from engagement with OFNHAEC and our First Nations partners. So I just want to emphasize that by working in partnership, we saw why First Nations ways of knowing are important to these administrative data studies. So if we were to not work in partnership on this, we would not have learned that many of the variables that are essentially normal to observational studies, such as income quintile and some of the rurality indices, do not essentially work for this population. This also gave us the opportunity for relationship building and demonstrated that the use of these collaborative processes with First Nation partners so not only did this show that this work is feasible, but it showed that this work can be performed ethically and respectfully. And, this work also built capacity for researchers. So for non-First Nations researchers like me, they built capacity for First Nations research and the importance of data sovereignty, history, and reconciliation. And on our partner side, it also brought awareness to what administrative data holdings exist and what type of research and data can be used to further support First Nations research endeavors. And lastly, this work has really fostered trust. So the collaborative nature of this work has translated to further involvement with the Chiefs of Ontario, OFNHAEC, and other First Nations groups on larger research endeavors that have pushed beyond the bounds of this work to look at further Hep C studies and even work in other disease areas. So with that, I just want to thank you all for giving us the opportunity to present this webinar and share this work with you. And I just want to acknowledge our partners, OFNHAEC, our funding sources from CanHepC and the Canadian Institute of Health, CIHR, Canadian Institute of Health Research, and the research team of the grant involved that funded this research. Thanks.
Thank you so much, Andrew, Lindy, and Evelyn. That was a really wonderful presentation. Lots to digest there. And I know I have a few questions. So I think for those who are on the line, if you could please enter any questions you have in the Q&A pod, and we can get to those questions for our presenters. And while you are doing that, I can take moderator's prerogative to maybe start with the first question for our panelists. Maybe for Andrew, but also Lindy and Evelyn, the question would be, some of the data you have, Andrew, it's up until 2014, and obviously that's a little while ago now. If you maybe wanted to expand a little bit more about plans that you have or your collaborators on how we can look at more recent data on this.
Sure. So just recently, the Public Health Ontario and ICS have linked 2015 to end of 2018 data. It was relatively recent. I know at the time of these studies, only 1999 to 2014 was available. That being said, we are planning to update these studies, and we've already requested access, and we're going through the process of getting access to the updated 2015 to 18 data. So these studies will be updated. And we're also in the process of, with that data will come further studies looking at the cascade of care associated with infection, so we can identify where attrition is in the continuum of care for HCV. And we're also in the process of, we brought on a knowledge translation specialist to help us transform this work into reports that are accessible for OFNHAEC and that can be furthered to First Nation communities and partner organizations.
Great, thanks. And maybe kind of a follow-up to that for Lindy and Evelyn would be, in seeing some of that work translated back to the communities, what do you think has been, some of anything surprising, or is this new or different when it's been shared with communities, or has it changed behaviors or how people get tested or seek care?
It's Evelyn here. I can only speak for my community in Six Nations here. It's amazing that we actually have representative data now we can use. We were seeing the results with our testing strategies, which is our partnership we have with our local Ministry of Health approved hepatitis C team. Partnerships is the key, working with Indigenous communities, and the benefits are great. Our response has been really well with our community. And there was a great need, and we're trying to get people with treatment and in the cascade of care, retention. It's been a good partnership, and I was glad to see the data results with our research with Andrew.
So I guess I would like to respond in the fact that, this is just most recent for us. As Andrew had said, we have looking at somebody to kind of put this together for our decision makers, and especially our First Nations leadership, because they're not fully aware. We only presented this information so far at the Chiefs of Ontario Health Forum, so that was health directors. Not all chiefs are present. There are some chiefs that are present there, but I think once we put this into simple community presentation or fact sheets for our leadership in communities, I think it's going to raise a lot of flags for them and our health professionals working in our First Nation communities. But in order to tackle this, I think, yes, the partnership and trust with working with First Nations communities and members in our communities has to be built. And I know that there are a lot of interested groups out there that have been reaching out to communities and have been doing those kinds of testings or in communities, but not every community is at that stage. So we're trying to, encourage that.
Okay, thank you both. We do kind of have a few questions in the Q&A pod, so thanks for those who answered. I'll read the first one out. So I think it's just a clarification question around, is the prevalence of 2% in First Nations, is that amongst all First Nations or those living just in First Nations communities? And then follow up was, are there prevalence differences between communities in the Northwest versus Central or Southern communities?
So the prevalence of 2% that we cited is it's the overall prevalence among, so it's important to stress that the nature of the ICS data is we can only look at status First Nations population. So the 2%, it talks to the overall prevalence within status First Nation populations across all of Ontario. There was a difference in, sorry, the question disappeared. I don't know where it went. Oh, it went to a different tab. There were prevalence differences between the communities in Northwestern versus Central or Southern communities. I'm sorry, I don't have the measure in front of me right now. The paper is coming out soon. It was recently accepted, and both these manuscripts are coming out in CMHA Open relatively soon. And there were differences also, but within the paper we also included all the raw, crude, and rates and the numerators and denominators from them. Sorry, I know I just don't have the raw data in front of me.
It's okay. Well, we'll have to wait for the CMHA Open to get those details. Thank you.
Yeah, they should be out relatively soon.
Wonderful. So the next question is about if there's any promising practices to increase hepatitis C testing and diagnosis for Indigenous peoples in urban settings, particularly.
So that's maybe Evelyn and Lindy can shine light, because it's a tough question because we can't really see that within the administrative data. The administrative data essentially paints this broad, high-level picture, and I think further research will need to be done at the community level to see what strategies have worked and which haven't. Maybe Evelyn, you can comment on any promising practices.
I was just thinking, like with our urban Indigenous communities, there is that linkage back to your home communities a lot of times, and just having that awareness and connections do exist. Our people are very fluid in our territories and where we live. Just a cultural safety aspect, Indigenous awareness to reach out. And like Lindy was saying, that trust factor is huge, but you have to know a bit about who our people are, because our communities are all different. So you have to do some education and awareness within yourself. That's all I.
Thanks. I think the next question actually is maybe a kind of related topic to that. Oh, Lindy, if you're able to see it, please go ahead.
Okay, sorry. Yeah, I just wanted to build on that. Yes, and working with the urban Indigenous, I think that, mainstream needs to be more, I guess, educated on how to approach that through cultural competency. And as well, like Evelyn had said, that every First Nation is different, and we all are different. We're not all the same people. Our nations are run different. Our communities are run different. I have to, even as a First Nations individual myself, from a First Nation, I always have to follow that community's protocol. It's not just going to see the health director. It may be the chief requesting that, you send a letter of request. So it all depends on that community's protocol and how you approach them, and providing and developing that trust and partnership. So that's what I would suggest. It is be more informed, I guess, in your catchment area of First Nations and start learning more about them.
Wonderful, thank you both. I think the next two questions are kind of related around whether there's any recommendations for public health professionals with little or limited Indigenous cultural safety training. I think you've answered a little bit of that. If there's anything more you wanted to add, as well as other strategies that have worked in this. And Andrew, I mean, as your perspective, someone not from a First Nations background, how maybe things that you've learned along the way in your process. I think you touched on quite a few during your presentation. Is there anything else?
Sure. So
you wanted to share?
There's been, so in terms of the first question, so recommendations for how public health professionals. So I came into this research with most of my training being focused in HTA and quantitative research and stats and methods for economic evaluations. So to really orient myself with Indigenous cultural safety training, just some materials I can cite is, so CCO offers an online Indigenous cultural competency course that was really beneficial. The First Nations Information Government Center offers an online course also in OCAP principles and kind of gives you a history of why those OCAP principles exist. And and how to make sure you follow them. Now, at around the time of this research, the process of gaining access to the Indian Register at ICS was very new. So Dr. Jennifer Walker, who is the Indigenous Research Chair in Ontario, was brought in, and she helped to facilitate the building of those relationships. But we also, as members of the research team through ICS, we had the ability to participate in land-based trainings that within First Nation communities that also so not only oriented us more with the population, but also provided that context behind the data, because it's very easy to get lost in the quantitative data as you're going through your analyses. So it provided a lot of context behind the data. And in terms of the strategies we used in working with this population, so our first strategy that was really important was establishing a formalized research agreement between partners, and just really hashing out those principles of OCAP around who would maintain ownership of the data, how would requests to share the data and access be complied with, and just having that quarterly engagement from the beginning of the studies, from study conceptualization and throughout, co-interpreting the results together, and then having involvement and acknowledging our partners on the manuscripts and the reports that are coming out. So just having that involvement at every stage, I think that's been really important. And it also demonstrates our commitment to the partnership also as non-First Nations researchers, because it has been a huge learning experience for me.
Thank you. Some really important insights there. We have a couple more, I think, technical questions kind of coming up. So maybe for Andrew, first one was just to confirm what percentages of the HCV positive cohort lived within First Nations communities and without?
Sure. So I have a supplemental slide here because I wasn't able to present this. I'm sorry if it's a little small, but these are our demographic characteristics of our 3 cohorts. It'll also come out in the paper where we looked at, once again, individuals that were tested for a hep C infection at their earliest testing date, individuals that were diagnosed with infection, and those with no test record. And what I want to emphasize here is, maybe the next one, is so in each population we saw around 20 to 38% have a postal code or residence code that indicates they resided within a First Nations community. That being said, from other research on that, First Nations people are highly mobile, so there is that potential for misclassification because it relies on postal and residence code. But we did see around 20 to 37%. Right here. Sorry, I don't know if you can see that.
Sure. Great. The second one was a question about if you had any data available about hepatitis C seroconversions amongst First Nations individuals while on hemodialysis in particular.
So we did look at seroconversions in general in the paper. I think it was around 20%, but we didn't look specifically to hemodialysis. That being said, it could be done within the administrative data because there are those diagnostics codes specific to hemodialysis, and I'm sure it could be done. We didn't for this study. This study was more a higher level, just descriptive epidemiology focusing on HCV.
Okay. Yeah, I mean, certainly I think potential future area that there. One question about, is there the same degree of stigma regarding hepatitis C in First Nations communities as there is in non-First Nation communities? So I guess that's questions presuming a high level of stigma in non-First Nation communities.
Maybe I'll pass it over to Evelyn Hill and Lynn Jones, because I know there is the stigmatized risk factor of injection drug use that comes with hep C. Maybe they can comment on that.
Lindia, did you want to comment on that one?
Well, yes, I think there is always going to be that stigma associated with it, with HCV, just like HIV. There's always that stigma, discrimination, scared to seek support, healthcare support because of the stigma. So that's why a lot of our people, like Andrew said, are coming at late stage, especially our men. When it comes to HCV, they're at the late stage. And I see that living in a First Nations community, there is a lot of stigma when it comes to HCV and HIV. Even now, what another increase is, another stigma that people don't want to talk about is cancer. That's another scary thing. So, our peoples don't like to talk about these things. They're not open. So we've got to have those conversations in a culturally safe and appropriate setting with, the supports.
And I just wanted to add that in addition to the stigma associated with drug use, from materials such as the In Plain Sight report out of BC, there is also that general distrust of healthcare services among the population that affect those seeking access to care due to racism and social exclusion. So in addition to issues in accessibility of resources, especially within 1 in 4 First Nation communities are remote in Ontario, there is that stigma and distrust. So I think in terms of a Hep C treatment, there has been some research done on kind of a trauma-informed care approach and incorporating strategies that can help address that intergenerational trauma in their approach to tackling Hep C. Just something else to think about.
Someone had a comment in the Q&A around the pandemic as having affected the recovery of some of First Nations clients and adding to their struggles, that they had clients who wish to visit their home community but are often unable to do so. That was a question I had as well. As in the last year, obviously lots of change in our world through the pandemic. Do you see any shift in some of the progress that has been made around hepatitis C or other initiatives that has that been impacted? Have you seen testing rates? Have they declined through this last year due to the pandemic?
Maybe Evelyn, would you?
Definitely the pandemic has had an effect within our communities because of access. The rates have gone down, like with everything, trying to access for testing. Facilities are closed a lot of times to the public. So a lot of our Know Your Status campaigns was outreach and within the communities, and those are on hold. But our people are resilient and strong, and they can still reach out. So we still have connections. Testing is less, but still ongoing. Referrals are ongoing to it with our shelter, our Hep C teams. So it's less, but we're still trying to maintain and keep the connections alive. So we're working together. But it is hard. It's pandemic affects everything. So.
Yeah, and I just want to add to that, to Evelyn's comments there, that yes, we've seen since the pandemic, not very many of our people are accessing healthcare or getting tested at this time. It's low on the bar right now. I think a lot of our people are heightened with mental health issues and trying to get mental health supports, or right now trying to get into our communities or asking our communities to facilitate vaccine rollout, where they can go if they're off the reserve, or if they're going to be coming back into our communities, where some of our communities are allowing our off-reserve members to come in just to get, the vaccine. So that has taken a heightened approach. I know we have a lot of our people that have diabetes, and we're worried about, their health care because it has been limited, or access, especially those that have to travel out from their communities to get to see their doctors or whatever. So there has been some challenges in that. So yeah, it's been hard.
Thank you both for sharing those insights. I don't know if that's maybe something you can add in the type response that someone was asking if maybe you could provide the names of the Indigenous training you had mentioned. I think the Cancer Care Ontario and the.
Sure, I can send that out. Maybe I can
something that could be shared afterwards. There is also another question about if there's any information availability, accessibility, and acceptance of HCV treatment for First Nations communities.
So so as a part of the next steps in this research, this is just the first two papers. Once we get access to the 2015-18 data, our next step would be to look at the cascade of care specific to First Nations people, and that'll be able to kind of provide rates of how many are getting tested, but the resulting how many people from getting tested are being linked to further care and receiving treatment. So hopefully from that, because right now in this aggregate data, we have like estimates of how many have received treatment, but once again, this only spans from up to 2014, and those direct acting antivirals that have much better side effect profiles and have had a large impact on the treatment of HCV aren't really just came out in this data. So that'll be a part of our next work. We're in the process of performing that look at cascade of care.
Interesting question here, I guess for Lindy or Evelyn, around, do you think that there could be any opportunity to partner viral testing for hepatitis C, B, or HIV with the COVID-19 vaccine rollout in communities that have follow-up doses to come?
The issue thing with, the partnerships is we need to look at all the variables and the issues within the communities. And I know in the future, I've done several other webinars with issues revolving around that issue of testing for point of care testing for STBBIs, probably something similar to what they're doing in Saskatchewan First Nations territories. But at the present right now with our COVID vaccine rollout, we're just pretty much focused on COVID-19. Our populations are large, and it's a priority right now, but something to think about in the future, for sure.
Thanks so much. I think that's the questions we have in the chat box now. I don't know if there's anything else, Andrew, Lindy, or Evelyn, that you wanted to say to any of the questions that have been posed, or any other kind of future directions you're thinking about for some of this work.
Well, I guess I just would like to finish off by saying the last comments would be that this is just a start of our research. As Andrew has said, this is from just, from 2006 to 2014. We'll hopefully have more recent data. We have to look at further research on, I know some questions came forward today to look at some more areas of research. So I think that, this is a starting point for us. And I think that, I think our partnership and our research today has led a pathway for others to start beginning that process as well. Because the fact that we have a data governance committee here in Ontario for First Nations communities that is housed out of the Chiefs of Ontario. I was hesitant to be involved as a partner, not knowing much, heard all the, the things, the scary stories and studies about being researched by others and not having access, control, possession, those kinds of things. But now I see that, and this will be a learning for others to pave the pathway forward, I see. Because we really do need this kind of information to inform our First Nations leaders, to form our healthcare people in our communities. Thank you.
Yeah, and just with Lydia said, I think with the relatively new linkage of the Indian Register to ICS administrative databases, it's projects like the very little research the research is really just starting to come out around dementia, diabetes, and now Hep C using that linkage of those data sources. So it's important to show that this data is available and feasible, especially to First Nations communities, where they can submit their applied health research questions, and work in partnership with ICS to examine these topics on a much wider scale. It's just important to show that it's feasible and it's a possibility now.
Well, I hope there's some way that you can capture some Lydia's and Evelyn's comments right now about the learning experience of the partnership, and if there's a way to, beyond the results of your research, just how this process has gone, and a way to share that with the larger community, because I think there's a lot of really important lessons that have been learned with that. Thank you so much for sharing those with us today. I do want to thank all of the, first of all, Andrew, Evelyn, and Lydia for presenting. Thank you for sharing your work with us today. I'd also like to thank everyone who's joined us for today's session. It's great to see such strong virtual participation, and during such a challenging time for many people to make the time to participate in this kind of round session. To access any past Public Health Ontario rounds presentations and view confirmed upcoming events, please visit our PHO website and head to the Education and Events page and click on Presentations. Lastly, you can expect to receive a brief and anonymous PHO rounds survey for today's session shortly after the close of this presentation. If you could please try to complete this to help us improve our programming. Thank you so much and have a wonderful day, everyone.